consortium of doctors working on diagnostic and treatment guidelines for PANDAS, and he was one of the key contributors to the JCAP guidelines, and they'll cover a lot of that tomorrow, I believe. Dr. Pasternack was telling us last night that he's got an extensive inpatient caseload at the hospital, and he's seeing kids with PANDAS mostly as outpatients, and he works 7 days a week and is cramming in as many kids as he can and doesn't sleep enough. So we really appreciate her works there. Because of talking with him last night, I know that that work ethic is really because of the heart he has for kids and helping these families, and I just really admire that. There's no PANDAS clinic in his city, so he's kind of flying solo on a lot of this and taking on way too many kids. There is some support, but he's doing a lot of this work, not as part of a clinic. And we just really appreciate you taking the time to come speak with us and teach us, so thank you.
Make this work, we'll be in great shape. Let's see. Well, it's a pleasure to be here. By being the third speaker, there are certain things one is obliged to repeat, which is to thank the hospitality of our hosts and the opportunity to speak here. There'll be some overlap with earlier speakers, and I think it's helpful because it just shows each of our slants. And I understand this is quite a mixed audience, and I will try to cover all the bases. And if you are confused, we'll have plenty of time to talk about it afterward. My wife volunteers as a mediator in the district court, and she says that a good mediation means that no one leaves happy. And so I hope not to put in quite that category, but that said, we'll try. I don't have any, the slides are not, sorry. They look very pretty here, but, I think I have to open it, this one. No, it's this one.
Is this you?
Yeah. Yeah.
You just do a slideshow.
Oh, okay, great. Okay. Yeah.
That or this?
Yeah, that's fine. I don't have much in the way of conflict of interest. And I'd like to speak today on a number of topics that I hope will flow from one to another. We've heard bits and pieces of some of these concepts, and I think of this as an opportunity to share my philosophy and the evolution of my thinking, not just to cover data. We will spend tomorrow speaking in greater detail about details of therapy, at least from infectious disease or antibiotic perspective, but I will touch a little bit about that as well today. I just put this slide up. This is actually something that Tanya Murphy had suggested. It points out that in 1 year, through a simple literature search, I could find a whole bunch of references that relate to infectious triggers and psychiatric disorders or psychiatric problems. And there's no theme here except to say that that's the theme, that infectious disease presumably sets off an inflammatory reaction that results in behavioral problems. One of the most provocative papers is the last one listed that you can see, I guess, oops, this is not going well. Let's see. Bob, if I can trouble you to fix that, is that one of the challenges in associating any infectious trigger, or any trigger for that matter, with subsequent, I hit this button, I guess that's not the button to hit. Oh.
And then forward is this.
Oh, okay, great, that's what I'll keep. One of the challenges is that, as you can see in the lower right, the time delay, the latent period between an infectious trigger and a readout, in this case, a tic disorder readout, was measured in years and was not correlated with the severity of the initial illness. And this was published in Medicine, which is normally a very respectable referenced and refereed journal, but the notion that we would find more of these correlations were we to look harder, I think is real, and just shows the challenges we have ahead of us, particularly in thinking about issues like PANDAS, where we put the strep issue aside, which is, as I'll show you, is not so easily done. This is a drawing of Thomas Sydenham, known as the English Hippocrates. And I show this because it was close to 350 years ago that he first observed chorea and got his name put on it. I learned that St. Vitus was the patron saint of dancers, so it's kind of circuitous. But he noticed this and noticed their behavioral issues over 300 years ago, and it's taken a long time to link all the pieces that associated chorea with what was called childhood rheumatism or juvenile rheumatism several hundred years ago, and that, as you can see, the valvular disease associated with childhood rheumatism, which we would now call acute rheumatic fever, was first appreciated about the same time, 100 years or so after his publication. The germ theory of disease took another 100 years to appear, and progress has been a little more recent in the last century. Group A strep was identified and characterized, and its role in provoking acute rheumatic fever became prominent during World War II. If any of you want to know about the importance of Group A strep and penicillin in acute rheumatic fever, you should see the movie The Third Man, which is based on a great plot that involves just these issues in the time of World War II. I won't say anything more because I don't want to spoil the movie. And I know that the use of prophylactic antibiotics or suppressive antibiotics in the prevention of recurrent acute rheumatic fever is really a hallmark of this 325 years of progress, because it is the prevention of the next bout of acute rheumatic fever that gets cardiologists excited, because patients typically don't develop life-threatening or chronic rheumatic heart disease based on an initial episode, but on the second flare and the third flare. And places like Brazil and other parts of the world where there's urban crowding and inadequate medical care and late diagnosis, if any, of strep, acute rheumatic fever and rheumatic heart disease is a continuing challenge. So why does Group A strep pharyngitis lead to the development of acute rheumatic fever, to PANDAS, to anything else? And the term molecular mimicry has been mentioned, and it was an incredible insight. And I want to say that this is not unique to Group A strep, and it's not unique to acute rheumatic fever or to PANDAS. There is a list of a number of infections that trigger non-infectious complications. Probably the best is Guillain-Barré syndrome, which is a neurological condition where you develop peripheral neuropathy. You become paralyzed, basically, and if you're unlucky, you can't breathe, and you spend 6 weeks or 3 months ventilated in an ICU, and slowly you hope to get better and get out of the hospital. This is caused by an intestinal germ called Campylobacter. The coating of the Campylobacter germ cross-reacts with the lipid, the fatty tissue or fatty material that envelops nerves to promote their electrical conduction. And so it's an unfortunate coincidence that this germ can trigger an immune response that destroys our peripheral nerves. And that concept of molecular mimicry is really widespread, and in the case of in this hypothetical microbe and host, you can see the single letter code of the amino acids. There are 20 amino acids. These are the building blocks of our proteins. And our immune system is totally fixated on the details of those amino acid linkages. And so you can see that a germ, a microbe listed there, has a particular 5 amino acid sequence. It happens to be shared by one of the proteins in our body. We make lots of different proteins into five amino acids that resemble some germ's sequence. Isn't that hard to come by? And the reason that this is important is that when antibodies are made by our body, by our immune system against the offending germ, those antibodies may happen to target that 5 amino acid sequence and thereby cross-react with our own tissues. And this doesn't project in great fashion, but Michael Oldstone was big on molecular mimicry. This was a review article he published, and he listed, he performed a project, a mission, to demonstrate the importance of molecular mimicry and autoreactive antibodies. And so in his lab, he made monoclonal antibodies, immortalized antibodies against a number of various infections, some rare, some common. And he would then just sum up how many of these react with human tissue or with mouse tissue in this case, and how many don't. And it turned out he generated 815 different unique antibodies against this dozen or 15 pathogens, and 45 of them, about 5%, turned out to be cross-reactive. So the notion that an infection triggers cross-reactive antibodies is not some rare struck-by-lightning phenomenon, but is actually the cost of doing business from the immune system's point of view. This is true, obviously, for B cells, for the antibody-producing arm of the immune system, but it's also true for the T cells. It's harder to make a cartoon that displays this, but the number one on the left, you can imagine that T cells don't see intact proteins, they see chopped up pieces of proteins, short peptides, and so that microbe sequence with the similar amino acids gets chopped up and it gets presented on an antigen presenting cell, and then a T cell recognizes that and is activated against the virus, but it also turns out to react to our own tissues, because some other peptide from the host cell with the same sequence is presented, and the T cell says, to me, they look alike. And in fact, that's the trigger for cell-mediated autoimmunity triggered by these molecular mimicry mechanisms. This is a figure that I took from Dritan Agalu's paper, which I think is a seminal one. This is where he and his laboratory infected mice repeatedly once a week simply by instilling group A strep in the noses of these poor mice, and then he studied what happened to their brain. And here's a pointer. Okay, so this is a section. He would take the excised mouse brains and make slices through the brain up and down just this way, and then look for how many mouse lymphocytes infiltrated that section of the brain. And he looked in control animals, which are in blue, and you can see that there were none. And he looked in the brains of mice that had been infected only once, and there was perhaps some signal here. But when the mice were infected repeatedly, 4 times over a month, there was this huge influx of immune cells in a very selective part of the brain, because you can see after the first few slices, the numbers come way down and largely disappear. And so that there's a specific autoimmune encephalitis triggered by the group A strep infection in the noses of these mice. And I think from a basic science and pathogenesis point of view, this figure is going to be famous for a very, very long time. I wish I had done it. So I have a few slides that relate to some of the clinical features that we've heard repeatedly, and bear with me for going through it. But this is a disease of childhood. As you know, boys are slightly more common than girls, but it's not to underplay the severity of illness among young girls, because maybe the parents or society has a greater expectation of perfection, but there are a few mild cases, I would say. And obviously, if we're talking about pandas, where strep is in the title, hopefully there'll be a significant association with strep. So this is a sort of tautology, but has a high rate all the same. The features we've heard about, and I think everyone in this room is, if not already expert, is rather expert. And this morning's videos, I think, will make everybody expert. This typically occurs in children, although I must say that I've seen a couple of young adults referred to me with symptoms beginning in college. In one case, right after college, the patient was an engineer who graduated college with a degree, had an engineering job, and he got fired because he obsessed on his calculations. So he would do his work, and he would recheck it 50, 60, or 100 times. And the boss would come by and say, well, how's that building or bridge or whatever coming along? And he said, I'm just checking. And he wound up losing his job. And he got put on oral antibiotics and nothing more. And got a new job and is an engineer and working and is functional. And I think the severity of symptoms, like any medical condition, has a broad spectrum. We tend to see, and as a referral practice, I tend to see a lot of severely afflicted children, but it's not universal. And so I think the milder cases, the children with more isolated symptomatology, often respond, particularly when coming in acutely or early on, respond quite well to rather low-level treatments, and it made a believer out of me. And I say to the non-believers, if they would spend a day in my office, hopefully I would make a believer out of them as well. And I listed here at the bottom some additional support, at least for me it's additional support, which is that if kids improve when given antibiotic therapy against group A strep, it's hard to argue that group A strep is probably playing a causal role. It's particularly true when given penicillins, or what we call beta-lactam antibiotics, the superfamily of drugs that would include cephalosporins as well as penicillins. Azithromycin is actually a broader spectrum agent, and responding to azithromycin it neither supports nor denies the possibility of strep as a causative agent. The presence of autoantibodies reacting with neural antigens is helpful, I think, when dramatically positive. I think many children with significant symptomatology have somewhat equivocal test results to me, and I find it challenging to interpret. But I would say that if I were to see children with their first round of symptoms, or maybe early after a flare, they get an appointment to see me when the secretary books an appointment. It's not always the clinically most dramatic time to come in. I have a feeling that some of this testing would be more informative if it could be stratified as a function of illness course. And of course, the response to immunomodulatory therapy supports the diagnosis that we're dealing with an inflammatory neurologic disorder. I have to say, I've read a lot of lists of clinical symptomatology relating to lots of different diseases, but it's as if the children in my practice read the list, because the majority of them really have the classic multiplicity of symptomatology, and they're such unique symptoms. They leave my office twice during the time they go to the bathroom before they come in, and then they leave 2 or 3 times to pee while I'm talking, which is often helpful for me to talk to the parents. But the sleep disorders, the meltdowns, all of the things that we've heard about are just so classic and dramatic that you can't just say this is a tic disorder or this is just a childhood onset OCD. The school performance issues are not universal, but they're quite dramatic. These are children who were at the top of their classes who forget their multiplication tables, they forget their arithmetic tables. Their OCD is such that they erase through their homework assignment sheet to the point that they can't hand it in because there are holes where all the answers should be. They've written it, written it, and erased it over and over again. And so it's really quite dramatic. And again, sitting in my office, it's clear that this is a rather unique presentation. I've listed from Dr. Suedo's work a whole list of other symptoms that I like to show. I like people to understand it's not just the major league headlines, but a number of other things. The complaints about mydriasis, the big dilated pupils, the deer in the headlight phenomenon, is really classic. The sleep disturbances and the so-called allergic shiners, the rings under their eyes, are common things. The sensory hypersensitivity issue is another real thing. I can tell just by what the child is wearing walking into my office as to what I'm up against, because very few kids come in blue jeans. They're all in sweatpants, or else they're in shorts in January, and Crocs, the open sandals. And I say something to the mom, did he dress up special for me? And the answer is no. In fact, that's all he wears. And she said, I have 5 others of the same T-shirt and the same shorts, but they're no good. It has to be this pair. And sometimes the fabric is so frayed that it's really an issue. And so that many of the things here are very dramatic. They're easy to discern. This doesn't require a questionnaire. Not that they're not valuable, but this is not technically challenging. The differential diagnosis is real. We would hate to go down a garden path in the wrong direction. But most of these are relatively straightforward. I would say that the autoimmune encephalitis category, as Dr. Tinneman mentioned, is really challenging because the laboratory confirmation of this diagnosis is barely positive half the time. And getting my neurology colleagues to even go down that path is very challenging. Even when kids are in the hospital and totally dysfunctional, they simply don't want to do an LP, and they don't want to send the samples off to the Mayo Clinic to get answers. And if we do and they come back negative, they say, see, it wasn't AE. But if there's another child in whom they think has AE, the negative test, oh, it's fine. You know, we can deal with this. They use it as an excuse to not pursue immunotherapy. So to me, as an infectious disease person, the challenge between PANDS, which argues for at least antibiotic support that is different in many cases from that of PANDAS, is one of diagnosis. You think, well, strep, how hard could it be to diagnose? And as I'll show you, it's actually hard to diagnose. And the question can be asked, is it worth the bother? And that's a whole separate and valid question. But if you think of PANS as the universe of these behavioral disorders, and think of PANDAS as the etiologically proven subset of that population due to strep, the question is, how big do we draw the circle? The ones with confirmed group A strep infection are kind of easy to put in the yellow box. The question is, what about all the maybe cases? And this turns out to be very challenging from an infectious disease diagnostic perspective. Again, in part because I'm not seeing them from day one till the time of confirmed diagnosis, but also because the technology is actually terrible. And I wouldn't have believed I could say that in 2019. We're talking about tests that were developed literally before I was born. And yet, they just aren't that good, and I'll show you exactly what I mean. So, what are the challenges between finding out is your child within the yellow dotted line or outside or in, and so on? And it's that the diagnosis of group A strep is not so straightforward. As I'll show you, group A strep is not one pathogen. It's a family of pathogens with great microbiologic diversity. And if you think of that little cartoon of the molecular mimicry, where one protein may have a particular sequence that triggers an autoimmune reaction, and then you think that there are over 100 different group A streps, you can see that not all group A streps are the same, not all group A strep pharyngitis are the same, and not all non-infectious sequelae can be expected to be the same. So we have limitations in microbial diagnosis for any of the clinicians who've tried to do a throat swab in a patient with PANDAS or PANS in the middle of a flare. I take my hat off to you. I'm lucky I still have my fingers. When these children do not want to open their mouth, there is simply no way to get a culture. And if they're young enough and you're strong enough and you can get a culture, trust me, it isn't necessarily the ideal bilateral swabbing of the tonsils and the back of the throat and so on. And it's a challenge, and I'm sure that there's a substantial rate of false negative cultures just in the clinic because it's technically challenging. I'll speak at length about the serologic diagnosis, which is actually problematic because it's simply not sensitive enough. It's not that there's a specificity issue, although there's some specificity challenges. It's just not sensitive enough. And the limitations of treatment we'll talk about. So, as I said, the difference between PANDAS and PANS comes down to, well, did you make a diagnosis of group A strep infection? Because if you did, you put them in the PANDAS category. It comes down to when did you do the test and what test did you do? And for primary care doctors, for family practitioners, you were at least seeing the child acutely in the early stages of a flare. And the possibility of recovering group A strep is greatest. Patients may schedule an appointment with me until they come in to see me. I'm sure it's true at Stanford as well, that maybe the worst of the storm has passed. And then all the microbial sampling of throat cultures or anal cultures or whatever other cultures, it just turns out it missed it because it's just not prominent at that point. I don't have a good sense of the threshold, of the sensitivity threshold. How many strep do you need to get on that swab to have a positive report? I mean, the lab will report out 2 or 3 colonies, but what does that mean? How much strep had to be on the throat? I'm convinced that many of the children who are diagnosed with PANS probably had group A strep infection, but for reasons either due to culturing or due to some other issues that I'll show you, just didn't turn that swab positive. And so they're in this sort of uncertainty issue. The The diagnosis of non-group A strep infections as potential triggers for symptoms is a real issue. If you speak to most families whose children have had at least 1 or 2 flares in the course of their waxing and waning illness, it's common to get a history that, well, we were fine after an episode or 2, we got treated, things were going on an even keel, and then my son got influenza. Or my daughter broke her forearm, or something like that. Some trigger occurs that's not group A strep, and it's not some other respiratory pathogen, but it triggered an inflammatory reaction that led to a symptom flare. So I tell everyone that Dr. Suedo insists that at the NIH all the children had to get flu shots. I said, don't worry about the risk of a flu shot triggering a flare. It's generally very low-level risk, and the flares are very mild in general. Just imagine what your child would do if he or she got influenza. But the notion that non-infectious or non-bacterial triggers occur makes a diagnosis for us in the clinic much harder because we didn't necessarily see the child earlier on. I will talk about serological monitoring. You know, kids come in and they've had ASLO titers and anti-DNase B titers and mycoplasma titers, have a whole table, a whole page full of numbers. What to do about it and how to even interpret it is challenging, as I'll show you. I'll speak about why some kids fail conventional acute rheumatic fever prophylaxis therapies or even full-dose treatment therapies. And it's been my personal position and sort of supported by conversation, but not that of anything I've seen published, that antibiotic doses tend to have to be higher in treating kids with PANDAS. And I don't have a good explanation except to show you some theoretical possibilities. And I've listed here some of the second-line agents. So cephalosporins are basically first cousin of penicillins, and they are very good anti-streptococcal treatments. Amoxicillin clavulanate is Augmentin, which is a wonderful antibiotic. It's sort of my gold standard if kids can tolerate it. Azithromycin is the gold standard for treating PANS, but it's actually it's a good all-purpose drug, but it's neither perfect for mycoplasma nor is it perfect for group A strep. So you kind of make a deal with the devil that it's easy to give, but you may not actually cover all the bases. And clindamycin is a drug that has the reputation of being the best, and it's actually not the best, but it's hard to give in most cases. So in the laboratory, or at least in the office, if I see a new patient, I look hard for group A strep, and it was Mike Cooperstock who stressed to me how important it is. Getting a throat culture is great, but getting a rectal swab is also important, and just simply asking the parents, how often does your child have a red bum or a red circle around the perianal area? And oh yeah, we see that. They may not have it today, but that's a good enough history for me to know that they're strep carriers. Remember that group A strep infection is not limited to the throat or to the perianal area, but can cause infections in areas that aren't so routinely or easily cultured. So sinusitis is a classic disaster because we can't really get cultures in the sinus unless an ENT surgeon, is involved and can get deeper cultures. Impetigo, the superficial bacterial skin infection that is commonly seen in children with eczema, is commonly caused by group A strep. But it's not, unless there's really juicy stuff to culture, it's not usually cultured. It's just presumed to be a mixture of staph and strep. But we actually don't know, and it's important to know. Guttate psoriasis is a non-infectious rash. They're small little areas of psoriasis that kids get out of the blue. It is sort of pathognomonic of prior strep infection. So it's another non-infectious sequela of streptococcal infection. So if I see a child with a history of guttate psoriasis, then I know I'm dealing with strep. We're going to talk about the antibody testing, and I just want to mention that one has to have an open mind about other possibilities. Where I practice in Massachusetts, Lyme disease is like everywhere. And every parent with a child with a perplexing illness is convinced that that child has Lyme disease and the doctors have just failed to recognize it. So I have this Lyme disease burden, which I don't think applies here in Saskatchewan and doesn't apply to the small tick parts of North America. But there are times that, in fact, personally I've seen a case or two of children who got symptomatic after Lyme disease, so I think it's real. For me, the big challenge is the timing of evaluation in relation to the onset of symptoms. If at Stanford it took 2 years on average from the onset of the first symptom to the time they came in, it's at least that for us as well. So that's problematic. We do a little bit of additional screening. There are some clinicians who order $10,000 or $20,000 worth of tests. I don't find most of that information useful, and I don't do it, but screening for simple immune deficiencies is not unreasonable, but I wouldn't say that it's critical. Again, simple phlebotomy in many of these children is quite problematic because they're just so anxious that say we're going to send it to the lab and have a blood sample, again, is sort of like, I just want to get a throat culture. You know, it's hard to do. So why is it hard to document the role of group A strep? Well, group A strep, we're all taught in medical school, lives on the surface of the tonsils. That's why we swab them. It turns out the interaction between group A strep and the tonsillar epithelium is actually complex, that group A strep can engender changes in the cytoskeleton, in the microscopic scaffolding of the cells that create pores that allow the bacteria to get into the cells. So we think of group A strep as an extracellular pathogen, a germ that lives, outside the internal environment of the cells, and antibiotics like penicillin and augmentin and so on get there quite easily. But if they live inside the cells, if they get in through these gateways, this looks like one of those late night clubs in New York in the 80s, where everyone's lining up to get in. Once they're inside the cell, the conventional antibiotic treatment is ineffective because those antibiotics have a negative charge. They can't get across the cell membrane. And so infections can persist, and yet if you swab the throat, you'll miss it. And it's a common anecdotal theme. I don't have any good data. I keep waiting for our consortium colleagues to publish their experience on tonsillectomy with a detailed analysis of what did they find in the tonsils. Normally when a tonsillectomy is performed and the tonsils are submitted for pathology, the pathologist doesn't do anything. They put down tonsils, a gross diagnosis only, meaning they looked at it and said tonsils and threw them away. So I ask when a patient of mine is having a tonsillectomy that they be sectioned and that the internal structure get cultured. And it's not unusual to get a report of group A strep out of the innards of the tonsil, or to get Staph aureus out of the tonsil, or some other bona fide pathogen, even though surface cultures were not effective or helpful. So a negative throat culture doesn't exclude the possibility of group A strep, but it does have implications for antibiotic failure. For the reasons that I mentioned, the antibiotics that we use most cannot get inside the cell. And what about amoxicillin? Why does amoxicillin fail? Children come in with a primary strep throat and they're given amoxicillin, and then they get a second symptomatic pharyngitis 2 weeks later. And it's not that amoxicillin has failed, because group A strep remains exquisitely susceptible to amoxicillin. It's that the environment of the pharynx, the oral pharynx, has become a very bad neighborhood for antibiotics, because the other germs, the so-called normal flora, the strep, the non-named strep that live on the surface of the tonsils and in the crypts of the tonsils and all around the mouth, have developed the enzymatic capability of destroying amoxicillin. They break it open and it doesn't work. And so those are the beta-lactamases, the enzymes that destroy the beta-lactam antibiotics. And so we have to use stronger antibiotics. We'll talk about this more tomorrow. But there's actually data that shows that cephalexin, Keflex, is a better agent for treating strep if cure happens to be your endpoint, which seems like a reasonable endpoint. And azithromycin, as I mentioned, is a great drug because it does penetrate cells. It treats intracellular pathogens. The problem is it doesn't treat all strep. So I'm going to spend a couple of minutes talking about group A strep. This is data that was pulled together by the Centers for Disease Control in the US. This was not based on throat culture data, but on basically bloodstream infection or sterile site infection, so invasive group A strep. But I think it proves the point well enough, which is that, first of all, as you all know, this is an annual predictable disaster, that every year in the colder weather, here's January, start of the winter, and into the early spring, there's going to be a group A strep outbreak. It's just inevitable. And unlike, say, pertussis, where some years are quiet, this is just predictable and it's every year. But what's important is, and I alluded to before, is that this is not one monolithic strain. Group A strep carries a protein called the M protein that is identifiable by protein analytic techniques. It's important for invasiveness of group A strep, and it's kind of like the barcode or scanning feature of the isolate. And the M protein number 1 is the most common strain, so it's not surprising to see that that's the most common. But you can see all those other numbers randomly listed down here are simply the other M protein strains that were recovered by frequency. And so out of the roughly 200 strains, these were 23, I think, represented about 90% of the isolates. So there's a whole bunch of strains that occur very sporadically. I gave a talk on pandas at my hospital's postgraduate course last December, and somebody stood up and said, you know, this whole thing was just not so. And he said, you know, we've been treating strep for generations. Why suddenly now is there a problem? And I said, if you can give me the group A strep isolates and let me characterize their M proteins and who knows what other microbiologic features of the germs, then we can have a conversation. But to say that pandas doesn't exist because you can't discern the distinct differences amongst all these different strains, you know, that's your problem, that's not my problem. The irony is that rapid strep testing, which is so convenient and so helpful in the office in real time, in a way has stymied progress in this field because we no longer get the strains. And so the notion that clinicians can recover the group A strep isolates and have them put in a central repository for future analysis is actually very, very helpful. And that would be helpful both for healthy kids with uncomplicated strep as well as for children with pandas who get sick. The Centaur criteria are the sort of thing that academic general pediatricians and general medical people talk about all the time as criteria for diagnosing group A strep. And I have 2 different slides that basically say the same thing. You can see that there are some features like fever, the presence of exudates on the tonsil, the presence of swollen glands in the front of the neck, the absence of cough, which is a hallmark of viral disease, basically, and that you're young, because younger kids get group A strep much more than their adults. You come up with a center score, very simple. 1 point apiece, you lose a point if you're over 45. So thankfully, I don't have a sore throat. And then you can see that, in fact, even if you have all 5 features, you know, they say that's a high probability, but it's less than 3/4. It's maybe 2/3 likelihood that you can document a strep infection. So the center criteria are great if you're working in a clinic with no laboratory backup, and you know, you're treating a lot of children in a high throughput situation. It's a good start, but it by no means definitively makes the diagnosis. And so when pediatricians, particularly when kids have recurrent episodes, recurrent pandas flares, many, many times I get told by the parents, oh, the doctor refused to do a throat swab because they said either you're on antibiotics already or your child doesn't have any of the features of a strep throat, like forget about it. And I call them up and I insist they do it, and every winter, despite chronic antibiotic suppression, there are kids who have strep infection. This is just a corresponding slide with slightly different likelihood percentages, but the point is that this is not a straightforward diagnosis, and this actually comes from the American Heart Association, which has not exactly been fostering the growth and development of pandas, but it lists all the different clinical features of streptococcal infection. So younger children will often present not even listed here. They'll present with abdominal pain, which is a classic complaint. So my child woke up with a fever of 100.5 or 101 and belly pain, refused to eat breakfast. To me, that says she's got to get checked for strep, because it so commonly in younger children especially has a GI dominance in terms of its symptomatology. But you see there are many other features that are not on the Centaur guideline that may play into the diagnosis of group A strep, and it's hard to come up with a simple scoring system that includes all of these different features. These are a couple of quotations from Gene Stollerman, who was the group A strep guy in the 1950s and 60s, and I'll read it. although obviously you can all read it yourself. In other words, about 2/3 of streptococcal infections associated with an antibody rise, meaning an immune response, which supports the diagnosis of a bona fide infection, may occur as subclinical infections. These are the cases that never came to medical attention. These are the Army recruits who just showed up in sick bay with acute rheumatic fever. And the doctors would say, "Private, did you have a sore throat 2 weeks ago? Why didn't you come to sick bay?" And the private who's in basic training would say, "Of course I would have gone to sick bay if I had a sore throat. I don't want to go through basic training." So they had a captive audience with 100% incentive to seek early medical care. And yet 1/3 to 1/2 of all the recruits in the big epidemics of group A strep in the 1950s turned out not to have any primary symptoms. They had subclinical infection, they developed an antibody rise, and they came back with acute rheumatic fever. And then it goes on to say, it should be emphasized that only streptococcal infections which were associated with significant antibody responses produced rheumatic fever. And it goes on. So the antibody testing is key. Now, Gene Stolerman only had access to ASLO titers, which I'll show you are just not that good. So even he was missing cases of bona fide strep infection, even in his research kind of after the fact. The rise in antibody titers is sort of the gold standard. But again, unless you're in the front lines as a primary care provider, you don't get to see the children early on to document a rise in titer. So I have a bunch of slides to just show you some of the confusion and complexity in this domain. And I'm not, that's the main reason that I'm showing them. The details are less important. But this was from one of the early treatment papers, and it demonstrates that the ASLO, which was the hallmark of invasive group A strep pharyngitis, can be normal, and only the availability of a second antibody test can demonstrate a titer rise over the course of the next several months after initial contact. And here were 2 children who had antibody rises that were published. And this was worthy of a table because it was such a rare phenomenon at the time. But now there lots of kids have been tested. And this paper by Johnson is another paper I'll show you by a fellow named Highsmith that showed the limitations of conventional, commercially available group A strep antibody testing. So I hope I can see it. But this would be a rather classic case of a child who was well, had an episode of pharyngitis, and both the ASLO titer and the anti-DNase B titer went up. There are cases where only one goes up. In this case, the anti-DNase B, and the ASLO doesn't do too much. There are cases where this one went up and the other one didn't budge. This child, if you can make out at the bottom, these are the number of positive throat cultures he had. This child was clearly, quotes, a carrier. He was cultured 23 times and had group A strep every single time. And his titers, if anything, didn't do anything. They were elevated, but we don't know what prior infection elevated them, and he's now a carrier. But if he were to come and see me around here and had a positive throat culture and elevated titers, I would say this was clearly a documented group A strep infection. There are a few others here that point out that the ASLO titer is not unique to group A strep. There are 8 or so letter-named strep strains, A, B, C, D, and so on. And strep C and G can elevate the ASLO. Obviously, they won't elevate the anti-DNase B, which is more of a group A strep specific finding. But in many practices, all that is sent is ASLO, and it comes back positive, but it was positive for non-group A strep, which we would all say has a low risk of triggering PANDAS symptomatology as an initial infection, perhaps as a trigger for recurrence. It wouldn't be off the table. But the interpretation of these numbers, particularly over time with the complexity of these clinical courses, is a real problem. Highsmith did something even more insightful, I think, which was that his laboratory generated about a dozen different anti-group A strep antibody tests. So in addition to the 2 commercial tests that were available, the lab tested about 10 other things. And this was just one of many patients whose ASLO and anti-DNase B titers didn't budge. But what went up was the antibody reaction against the M protein of that particular strain, in this case, M protein 2, and had a high titer. And this was the name of one of his other research-based antibody tests. And in this paper, there's a table of about 50 children, of whom about at least 20% had negative ASLO and negative anti-DNase B, but had all kinds of other positive strep reactions. So if someone bothers to get an ASLO titer and an anti-DNase B titer and they come back negative, that doesn't take group A strep off the table. That probably helps to populate that dotted line circle of possible PANS, possible PANDAS, where the technology is just not letting us make a diagnosis. These are some others that he published. That was the one that I showed you here. In some cases, here's another one where the ASLO didn't budge, but the anti-DNase B went up, and then in this case, the antibodies against the M protein went up, as well as against another test antigen. And this is some of his summary data, which I think is worth sharing, which is that if you look at all children who acquired group A strep during the course of the study, testing for ASLO antibody activity together with anti-DNase B activity only gave a 67% response. So in other words, you could only pick up 2/3 of the cases by antibody testing. And if you added a third test, it went up to 76. And if you added any other of his 10 other tests, it got up to 98%. So this panel should be the next sort of PANDAS panel, but I haven't seen them rushing to do that. And among children who only had asymptomatic infection, they had a positive thorough culture, no symptoms, again, the anti-DNase B and ASLO went up 2/3 of the time, just as Gene Stollerman had predicted, but you needed to add some other test to increase the sensitivity to a meaningful level of activity. And if you go through all the different antibodies that were screened in this trial, you can see that the ASLO alone was less than 50%. The anti-DNase B was 45%. These others, the names are not so important. And even among the M proteins, you can only detect reactions among 32 of the 51 strains. So for whatever reason, group A strep is pretty good about being a stealth bomber and getting in and getting out without necessarily triggering a comprehensive antibody response. So for us to see children at some point down the road with an acute symptom flare, it's hard to know what role strep may or may not have had. But the notion that additional testing, even on a research basis, should be available, I think is a high priority. I'll say a few words about mycoplasma. This is the pathogen that is attributed, at least theoretically, to PANS in many cases, at least as a germ whose name we know and can pronounce, and is common. And so it's similar to group A strep, that is, there's a common childhood infection, and maybe a small percentage of children, because of genetic background or other reasons, wind up to develop neuropsychiatric complications. So mycoplasma pneumoniae is always known as walking pneumonia, but in fact, walking pneumonia is uncommon, and it's estimated that fewer than 10% of children who have evidence of mycoplasma infection ever had walking pneumonia. The bulk of the time, it simply causes a sore throat that's negative for strep, or it causes a flu-like illness or bronchitis with cough, and then gets better. It tends to travel through households a week, 5 to 7 days apart. So one sibling gets it, starts to turn the corner, get better, lo and behold, the little brother gets it, and it kind of goes that way. Then after caring for 2 children, one of the parents gets it, and then a week later the other parent gets it, and it kind of goes through the household among susceptibles. It's a germ that's difficult to grow. So unlike group A strep, where we do a swab and hope to recover the germ, swabbing for mycoplasma culture is simply not done. The yield is very low, and most labs aren't very good. You need to have a kind of mycoplasma whisperer to have even a 50% kind of culture return. So a lot of the articles talk about, well, if you want to make the diagnosis of mycoplasma pneumoniae, you should get PCR. Well, PCR is not exactly a real-time test. You have to get a specimen, it's sent out to a reference laboratory. They tend to batch them, and they run them when they have enough to run, so it may take a week or 10 days to get an answer. So if you're sitting there waiting, do I give azithromycin to treat possible mycoplasma infection, it's not very satisfying. You haven't really come to terms with that. because you'd like to do it at the start of illness, which again isn't always so easy. It's expensive, and in my hospital, for several years, they wouldn't allow us clinicians to order it at all, because they found that they spent over $100,000 for one positive. Because people check it off as a box to be checked off on a panel of tests, and they had low pre-test probability of having it, but they spent the money for it anyway. The other thing about mycoplasma testing is you get an IgM and an IgG response, and the IgG reflects prior infection, or at least subacute to prior infection. That's the National Guard. Those are the antibodies that are going to be there for a long time. The IgM antibodies are like the Marines. They come in right away, and they're supposed to disappear after a few months. But in the case of mycoplasma, the IgM antibodies remain reactive for months to years very often. It turns out it's a false positive reaction. The technology of the assay is such that these large sticky antibodies stick to the test material and read out as positive. You have to do a fluorescence test where you take the antibody sample, the serum sample, and incubate it directly on a glass slide containing dead bacteria, and you have to demonstrate that the antibodies actually stick to the bacteria. And it's a test that's just not widely available. At least in the States, Mayo Labs they offer it clinically, and they will perform it for us. And so it's routine. I meant to do a screenshot, cut and paste, of someone whose mycoplasma titers were positive, but then there's a little asterisk at the bottom. It says the IFA test was negative, meaning they had mycoplasma, but they don't have mycoplasma now. It's an old response. And the number of children who get tested over and over again, waiting for the IgM to disappear, and take a boatload of azithromycin, it's a common scenario, but not very helpful. I want to say a few words about antibiotics. I know we'll speak about this more tomorrow, but the American Heart Association guidelines for the prevention of acute rheumatic fever talks about years of antibody prevention, of antibody administration for the prevention of recurrent acute rheumatic fever, recurrent strep infection. And so if you've had acute rheumatic fever with carditis, you're going to take antibiotics until you're 40. And if you miss one dose, they'll say you're going to have to come in every 3 weeks and get a shot of penicillin in your butt, because the breakthrough rate is felt to be very high with any breaks in the prevention at all. And if you have rheumatic fever without residual heart disease, you only have to be treated until you graduate from college. So when people gasp and say we are giving years of antibiotic therapy or even months of antibiotic therapy to treat children with PANS and PANDAS, where are they gasping? They're doing it themselves for acute rheumatic fever. It's just a matter of context. If you don't believe in PANDAS, then you don't believe in preventative protracted antibiotic therapy. People always are concerned about the microbiome. What about my child's gut bacteria? And studies have been done to demonstrate that whatever happens to the gut probably has happened after the first 2 weeks of treatment, because the sensitive germs are wiped out and the resistant germs remain resistant, so they carry on. And so I'm not sure there's much difference between a month of antibiotics and a year of antibiotics, personally. And I think as long as we respect that, we will be fine. I think the era of worrying about the microbiome and worrying about Clostridium difficile superinfection, had these problems existed in the 1950s, there'd be no prophylaxis for acute rheumatic fever. The community would have said it's too dangerous to give open-ended antibiotics for years. Everyone's going to get sick. But there is no middle-age syndrome of people with intestinal disease or other problems who were treated with long-term antibiotics in childhood. So whatever the problem is, it's more theoretical than practical. I also want to point out that these doses recommended for prophylaxis of acute rheumatic fever are quite low in comparison to what I find I need to use to get responses in children with PANDAS. And I'll speak some more about that tomorrow. I don't really have an answer, except that perhaps some of these intracellular protective sites of infection may be more real than we think. This slide, I pretty much said everything that's here, but it really derives from the fact that antibiotic prevention for acute rheumatic fever and for Sydenham's chorea has been proven to be efficacious and safe, and so we're just trying to apply a safe and efficacious treatment with a slightly different indication. But it's challenging because of the fact that there can be non-group A strep triggers, even in children with what we have considered documented PANDAS. And so the role of antibiotics kind of gets a bit confusing. Antibiotics are the foundational therapy from my point of view as an infectious disease person. And I've listed some of the commonly used things. For non-streptococcal infections, we use a lot of azithromycin, recognizing it's imperfect. For children old enough who can tolerate doxycycline, it's an alternative therapy for PANS. If any of you have taken doxycycline, you may or may not have found that easy to do. I don't know how the dermatologist gave that to teenagers for acne, because it often has a lot of GI side effects. But some of the ancillary therapies are very, very valuable, and they're simple. So the use of non-steroidal anti-inflammatory therapy should not be understated. One parent summed it up best and said her child, who by then was a 3rd or 4th grader, would come home and say, "Ma, I need ibuprofen." And he would settle down right away. It's interesting, we don't think of those drugs as having much of an intracerebral benefit, but they clearly have such an effect. I've been taught that naproxen is a better choice because it's longer acting. So if a child gets ibuprofen in the morning and goes off to school, and at midday the school nurse won't give another dose, this waxing and waning might be one thing for knee pain, but for behavioral issues, I think it's harder to kind of regain control. And naproxen basically gives 24 hours of coverage with 2 doses. The sleep is not my expertise, but I have been impressed that melatonin is often helpful. I've listed some of the other treatments that we're going to, I'm sure, discuss in greater detail tomorrow. And then I've listed a typical steroid pulsive given for an acute flare. This is sort of identical to what a child might get for poison ivy exposure or for an asthma attack out of the emergency room. So it's something that families can accept, although it's not big dose therapy as is used at Stanford to some degree. I think it comes back to those same haunting problems, that the diagnosis is difficult, the microbiological confirmation of diagnosis of triggering infection is difficult. The antibody testing is difficult not to perform, but difficult to interpret, and that the treatments have a higher failure rate than we would like, and it's quite problematic. So I'll stop now. I think we're going to now have our little question-answer thing, so if there are questions, I'll be happy to entertain them then. Thank you.